You're listening to Medscape's In Discussion series on endometrial cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ursula Matulonis, Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. She is the first recipient of the Brock Wilson Family Chair at the Dana-Farber Cancer Institute. She co-leads the Gynecologic Cancer Program within the Dana-Farber Harvard Cancer Center, the Ovarian Cancer Specialized Program in Research Excellence, SPORE grant, from the National Cancer Institute within the Dana-Farber Harvard Cancer Center, and an NCI P01 program project grant that is focused on targeting replication stress and high-grade endometrial cancers. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Ursula Matulonis. Welcome to Season 1 of the Medscape In Discussion Endometrial Cancer podcast series. Today, we'll discuss radiation oncology and its role in the treatment of endometrial cancer. Let me introduce my guest, Dr. Akila Viswanathan. Dr. Viswanathan is the director of Johns Hopkins Radiation Oncology and Molecular Radiation Sciences. She's the director of the National Capital Region for Radiation Oncology, and she's a professor of radiation oncology and molecular radiation sciences at Johns Hopkins University School of Medicine. Dr. Viswanathan, welcome to the Medscape In Discussion Endometrial Cancer podcast.
Thank you so much, Dr. Matulonis. It's wonderful to see you again and to be part of today's discussion on this Medscape podcast. Last time I saw you, I think, was at our Hopkins Endometrial Cancer Conference in Baltimore 2 years ago. And we got to speak about the combinations of radiation and immunotherapy for endometrial cancer. Certainly a lot has changed since that meeting and in the past 2 years. And I'm really excited to discuss some of those changes.
Our podcasts have really been focused on differences and updates and progress in systemic treatments. We had Mansoor Mirza talk about the addition of immunotherapy to chemotherapy, specifically checkpoint inhibitors. Katie Moore spoke about antibody-drug conjugates, and Joyce Liu talked about novel therapies such as CDK4/6 inhibitors and WEE1 inhibitors. So a lot's happening. And also, in the past 2 years since we saw each other in Baltimore, there's a new staging system. I'm really excited today to talk with you about the role of radiation therapy currently in endometrial cancer treatment and what the future of radiation therapy for this cancer looks like to you. So perhaps we can start off by having you discuss the role of radiation therapy in the treatment of endometrial cancer and how that has evolved and is evolving for endometrial cancer.
Well, Ursula, you know, it's been a whirlwind and it feels like we've had so many changes over the past really 20 years in endometrial cancer that keeping up and doing the best thing for our patients has really been keeping up with the data and monitoring this evolution. And if you go all the way back to the 1970s, radiation was a standard of care. We did radiation preoperatively for every single patient. And that has evolved to now us reserving radiation selectively based on pathologic features that are determined after the hysterectomy standard of care surgery is performed for those patients that are eligible for a hysterectomy, which is the majority of patients that are diagnosed based on symptoms being detected relatively early in this disease. And those pathologic features, historically, we looked at the depth of myometrial invasion, the presence of lymphovascular invasion, and the grade of the tumor, as well as whether or not there was spread to adjacent tissue or lymph nodes in particular. And that determined the role of radiation. So in patients that had the more aggressive features in the uterus, but that had not spread to the lymph nodes, we used a technique called vaginal brachytherapy, or treating the vaginal cuff. The patients that had spread to lymph nodes or the parameter or other pelvic tissues, we used external beam, treating the entire pelvic region to eradicate micrometastatic spread of residual disease after surgery. In the mid-2000s, there were trials that were looking at the role of chemotherapy as a novel treatment. Those clinical trials showed that there may be a benefit. Now, again, the original study compared an outdated chemotherapy to an outdated radiation called whole abdomen radiation. So, not really good comparisons compared to our modern data and modern treatments, but they did show a signal that chemotherapy may be effective. And that then resulted in the past 20 years of an evolution since 2004 of integrating more and more chemotherapy, as you've reviewed in this podcast before. In the modern era, we've been using carboplatin and paclitaxel chemotherapy, and the question came up after the publication of GOG 258 and the PORTEC 3 trials. What's the role of radiation? So the original studies that looked at whole abdomen and chemo did not use carbotaxol chemo. And so we still continued to integrate radiation. And there were many different ways whereby that integration occurred. Some people did it upfront and with chemotherapy. Some people did what's called a sandwich and put it right in the middle. And some people chose to give all the chemo and put it at the end. But an integration of radiation was considered standard for anyone with stage 3 lymph node positive disease. In the most recent phase, the past 5 years, the publication of the trials that I just mentioned, GOG 258 and PORTEC 3, were classic studies, but they used completely different standard of care arms. So the PORTEC 3 study compared radiation alone to concurrent chemo and radiation and showed that there was a survival benefit for combining chemo and radiation in patients with stage 3-4 disease. They actually also included aggressive stage 1 patients and higher. In the GOG 258 trial, chemo radiation was compared to chemo alone, and it showed that there were more distant metastases in patients that got the chemo and radiation, and more local pelvic and periortic recurrences in patients that got the chemotherapy alone. So different patterns of recurrence, but no difference in relapse or overall survival, questioning the role of radiation in those patients. Other studies, including the NCDB large data sets, have shown survival benefits of chemoradiation over chemo alone or radiation alone, leaving this lingering question about what is the role of radiation. So fast forward now to the most recent series of New England Journal studies that looked at the role of immunotherapy, so GY018 and the Ruby study. And these are immune checkpoint inhibitors, and both pembrolizumab and dostarlimab were tested in these two different trials. And again, in this aggressive subset of patients with stage 3 or 4 disease. The modern question is whether or not radiation should be given to these patients, and what is the integration of immunotherapy and radiation if radiation is indicated. So I'll start with that first question, should radiation be done? Well, in these modern studies, the Ruby and the GY018, they accrued patients that have residual disease. And the vast majority of patients that we see have had their nodes completely resected, the uterus completely resected, and so there is no residual disease. And so the vast majority of patients with stage 3 disease did not qualify for these trials. However, in order to give patients the benefit of the doubt, given the very large survival benefit to immunotherapy, there's been conversation, should these patients receive immunotherapy anyways, particularly if they are DMMR, that is mismatch repair deficient. And in those patients, there's a big question, and future trials are really needed to address whether or not immunotherapy is indicated. I will give you a quote from the Ruby trial of dostarlimab, and it says that there was no progression-free survival seen in the subgroup with stage 3 disease, and extended follow-up may be necessary to see if there is a benefit to patients with no disease at baseline because of the limited sample size and the relatively short follow-up period. So we are in a situation where we hope that future trials will address the issue of immunotherapy, but we don't know. So radiation remains an important component of treatment.
And it would be interesting to get your thoughts also on how the concept of multidisciplinary care gets superimposed. And I think it's so important now, given the two trials of trying to dissect the role of radiation therapy, with or without chemotherapy versus chemotherapy alone, and then the publication and now really vast FDA approvals for the use of checkpoint inhibitors in advanced disease, newly diagnosed, regardless of mismatch repair status, how patients get access to expert radiation oncologists and really get that benefit of your knowledge, your colleagues' knowledge, and understanding of the disease, and really how you interdigitate radiation into their care.
Before the immunotherapy trials were published, we created a standard by which patients would get carboplatin and Taxol for the full 6 cycles and then get radiation in order to ensure that both the distant metastatic risk, the risk of disease spread, and the local pelvic and periaortic node risk was addressed. And so patients received the best possible care by getting both treatments together. And I would say that now, in the era of potential immunotherapy, for patients that have residual disease, relying on immunotherapy alone to eradicate this requires them to receive potentially years of immunotherapy with some very significant toxicities that can occur. And radiation is a very limited time period, usually about 5 to 6 weeks of radiation is given. It's very targeted and can be given with very focused modern radiation techniques, and it's very cost effective. So the price to the patient and the healthcare system is 1/100th of the cost of the cycle of the immunotherapy agents. And so it's just an incredibly effective, cost effective type of treatment overall. Now, nothing is without side effects, and we acknowledge that. But side effects can be limited with good quality care and careful management, both during and after treatment.
How do we kind of enforce that or execute that multidisciplinary care to patients? Where I am, where you used to be, as you know, we have a joint tumor board with surgeons, med-oncs, and radiation oncologists. So radiation oncology gives an opinion about all new patients who cross our steps. Do you think that that is a good thing to do? Should teams be doing this type of care? Do you do this?
Absolutely. I consider it absolutely a hallmark of high quality care to have multidisciplinary interactions and having a good interaction between the GYN oncologist, that is the surgeon, the medical oncologist, and the radiation oncologist together. It's exemplified by the tumor board you mentioned. We do have a similar one at Johns Hopkins, and the openness of the providers to really want to follow the literature, to give high quality care, to really interact with each other in a meaningful way for patient care is unparalleled. How to distribute that around the country is a harder question because it's harder to find experts like yourself, a medical oncologist that's a GYN specialist in a smaller community setting. But I think what we do is offer the opportunity for people to do telemedicine in our states or to do remote consultation in order to help bridge the gap, if you will, for some centers where the patients may not necessarily be able to come in to a big academic medical center where multidisciplinary care can be provided.
And I'm sure you have community radiation oncologists who call you, email you, text you, which is another, I think, very acceptable. Sometimes you'd want to see the patient, but sometimes virtually you can see the patient. But having your expertise as a radiation oncologist who's expert in GYN cancer, specifically endometrial cancer, is really vital.
It's very important, I think, for patients to understand the value of having an expert team, like really subspecialized providers provide the best quality care.
I'm going to move on to another topic, the new 2023 FIGO staging, which has certainly generated a lot of discussion and maybe sometimes frustration, maybe not some frustration. How has that new staging system for endometrial cancer impacted treatment recommendations for radiation therapy? Or has it not?
For those of us that do endometrial cancer treatment all the time, the staging system, even for us, is extremely difficult to keep track of at our tumor boards. It's one of those conversations of like, what is this stage now? Whereas the historical standards, the stage had tracked along with subtle differences. This was a major difference. But I think it really makes sense because it combines a couple of features that in the modern era, we need to really be aware of. One is the importance of molecular features. The second is thinking about the downstream impact of staging on treatment. So, a couple of the changes are that there's now awareness that there's certain mutations that change prognosis. And one of those, like POL-E, when it's mutated, patients have a very low risk of recurrence, irrespective of other features. And so I think that is of high value for patients to know what the molecular phenotype is of the cancer. The other is P53 abnormalities. So papillary serous cancers are typically P53 mutated, but some other grade 3 endometrioids or other endometrioid clear cell cancers may be P53 mutated. And those patients have a very high risk of recurrence and are now automatically called stage 2 for early stage disease. And that indicates a benefit as seen in the PORTEC 1 and 2 data for radiation. So we are giving more pelvic radiation since the change of the staging system, because what is included in stage 2 is much broader and more correlated to the risk of local recurrence. So stage 1 are patients that basically now fit into the criteria of receiving vaginal brachytherapy, and stage 2 patients are now fit into the criteria of patients with cervical spread or substantial lymphovascular spread or aggressive histologic subtypes. And those are the three categories of patients that we see a true benefit for pelvic radiation. So at some level, from a radiation oncologist standpoint, the change in the staging system actually makes complete sense.
Yeah, that's interesting. It's a point of contention as we move forward, but obviously it's an interesting staging system in all the points that you just made. So thank you for that. I want to get your thoughts about where do you see the field of radiation oncology headed in the future for the treatment of endometrial cancer, and what gets you excited about the future for this field and for your field?
We go through all these ups and downs. 2 years ago, we talked about P53 mutated endometrial cancer. We would have said the patient would get vaginal brachy or chemo alone. Now we know that external beam radiation is indicated for these cases. So it goes back and forth, and we are getting more and more precise, I think, and more individualized in our treatment. So we're really tailoring and giving more precision radiation and more precision care overall. And so now we're doing things like stereotactic treatments at the time of recurrence and interdigitating that with what we talked about before, immunotherapy or chemotherapy. So we know that radiation triggers the antigen presentation to T cells and actually stimulates immunotherapy to be more effective. So our field is continually evolving, and radiation's been around since the early 1900s. It's over 125 years of existence. It's older than chemo or antibiotics, and it's existed and continued to exist for a reason. And some of it is really the effectiveness of the treatment in various scenarios. So, we can't deny or ignore that. And I think that the population of patients that need radiation will hopefully decrease to limit to those that will clearly benefit. I think we're learning a lot more about what those molecular features are and what the other features may be. And hopefully all those that appropriately qualify for radiation will be able to receive it, that we have adequate facilities in the US and worldwide to provide the treatment that will benefit patients.
And I think in line with your last statement, really moving to disparities, we had a whole podcast with Bhavana Padhuri from NYU. Alexi Wright also spoke about this, but endometrial cancer, as you know, has a significant and pressing problem with racial disparities and outcomes. And what do you think are some of the most pressing racial disparity issues related to radiation oncology that endometrial cancer patients who are underrepresented minorities face now?
I mentioned earlier an NCDB analysis, and a student at Johns Hopkins, Darian Colson-Fearon, just wrote up a series using NCDB looking at the disparities. And there is an enormous disparity in who receives pelvic radiation. African Americans are much less likely, when they have the node positive disease that I mentioned, to get referred for radiation, whereas patients that are not African American or not Hispanic are receiving pelvic radiation, whether that be because they are receiving a recommendation, whether that be because they are seeking out an expert opinion or a second opinion, whether they are more active online and reading about the pros and cons of radiation is unknown. But there is a glaring disparity in who is receiving pelvic radiation for stage 3C disease. And it's very clear that the African American population is underserved and therefore at a higher risk for pelvic and periaortic node recurrence. And, subsequent treatments, obviously, that can be toxic. And it's hard to know, but at some level, there is evidence that we need to do better in terms of ensuring that populations that are at risk and the African American and Hispanic communities are aware of the benefits of radiation and are receiving appropriate referrals.
That's really amazing. How do you even begin to start to solve that problem? Because you're right, you mentioned a number of different reasons why that may be happening, but how do we take a problem like that where African American women are not receiving pelvic radiation therapy as much as non-Black women? And how do you start to solve that?
I would say that starting and working through education and community outreach, really like getting into the communities and saying this is a reason why we recommend or advocate for this as a physician, making oneself available to those communities and really ensuring that access is a high priority for us in underserved regions or inner city populations, right? That's a daunting and complex problem, but one that we all have a responsibility to address.
100% correct. Akila, any last comments that you'd like to share?
Thank you for taking the time. It's been great to be with you on this podcast. I hope this clarifies for the community some of the questions about the role of radiation. I would strongly advocate that we need to continue to do well and in some places do better in understanding the role of radiation for the future, but that it's not gone and still something we'd advocate for and recommend for our patients for all the right reasons.
Well, thank you so much. It's been great to see you, great to talk with you. You're such an expert in the field. It's really a pleasure and an honor to talk with you, Akila, today about this really important topic. And hearing about the racial disparities, again, really, really important. So thank you so much.
Thank you so much, Ursula. It's great to see you and talk to you again, too. So appreciate the opportunity.
So today we've talked to Dr. Akila Viswanathan about the role of radiation therapy in endometrial cancer. We talked about how she sees the field evolving, what the future looks like, how to institute radiation therapy with immunotherapy. She talked about the importance of the new 2023 FIGO staging system and how that's really helping define the role of radiation therapy. And then also talking about a really important topic of racial disparities and what some of her data and her colleagues' data has shown. So thank you so much for tuning in. Please take a moment to download the Medscape app to listen and to subscribe to this podcast series on endometrial cancer. This is Dr. Ursula Matulonis for the Medscape In Discussion Endometrial Cancer podcast.
Thanks for listening to Medscape's In Discussion Endometrial Cancer podcast series with our host, Dr. Ursula Matulonis. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on endometrial cancer.